Welcome. I'm Professor Eric Van Cutsem. I'm from Leuven, Belgium, and I work there as a GI oncologist. Welcome here at ESMO 2019 in Barcelona for this e-cancer educational session. I'm happy to be joined by Dr. Teresa Macarulla from Vall University in Barcelona. Teresa, welcome.
Thank you.
We will discuss on pancreatic cancer, difficult to treat disease these days. We're making some progress, and one of the important aspects where we made some progress this year was understanding the patients with the germline BRCA mutation were treated with olaparib. Teresa, can you update us a little bit on these data and also on the new quality of life data that were presented here at ESMO 2019?
Yeah, this year we presented the results of the quality of life in the patients included in the POLO trial. I think that's an important point, and it's important results because in the maintenance treatment in pancreatic cancer, we have to consider if the patient maintains the good quality of life. In fact, we want that patients that stop with the chemotherapy and the side effects of chemotherapy, we would like that those patients maintain that quality of life. And in fact, this analysis demonstrated that patients treated with olaparib maintain the quality of life with the same level as patients treated with placebo. So that's good because it means that we are controlling the tumor and we are not giving to the patient side effects that affect the quality of life of those patients with pancreatic cancer. But I think it's an important point.
What are the implications in your daily practice from the POLO study in view of the strategy, platinums and BRCA mutations, in view of the fact that we have the olaparib data, and in view of the fact that in many countries, many physicians often start with first-line treatment of gem/nab-paclitaxel, which is not the optimal setting in the BRCA mutant patients. How do you tackle that in Barcelona?
Yeah, we are dealing how to test BRCA in our situation, in our countries, in Europe. So now it's easy when you have a patient, a young patient, a patient with some other tumors or a high important family history of cancer. In these cases are easier because we normally start with FOLFIRINOX or with gemcitabine and cisplatin. It depends on the ECOG of the patient, and we perform the test of the BRCA test. But of course, the more difficult situation is what we can do in a patient with 60 years old with no family history of cancer, with no history of cancer, how we can test. The ideal situation is to test all our patients because we know that some patients presented these mutations without any other situation, but we have to deal with this in Europe. In this moment, it is not so easy.
And the trial was, the primary endpoint of the trial was progression-free survival on olaparib. Some people challenge us sometimes that there was not yet any survival benefit. Is that in your practice anything that has implications for you?
Of course, this trial was not powered to demonstrate a benefit in overall survival, and that's an important issue. Of course, and also the data is immature, so we have to wait more and see what happened with the curves. But also, I think that when you treat pancreatic cancer and you have a patient with a BRCA that responds to platinum and have this response, like in the POLO trial, it reported this more than 25% of the patient responds to olaparib, and then maintain this response for 2 years, for example, this is something that for sure in your patient impact in the overall survival. So for the trial we have to wait, but when you see in your clinics this kind of patients, for sure this patient benefits from the treatment and also the overall survival of those patients.
Mm-hmm. I completely agree. I share this experience also that there are some patients, it's of course not everybody, but who have a long-term benefit, and probably here the medians that will not reflect everything, and the trial was indeed not powered. The follow-up is short until the first analysis that we published, so we have to wait longer, but I do believe that also, therefore, the quality of life data that were presented here, that they are very important because there is no negative impact on the quality of life. Absolutely. With olaparib in this setting. If you change a little bit also in pancreatic cancer towards the adjuvant and neoadjuvant treatment, we've seen this year the data of gem/nab-paclitaxel, the APACT trial being presented, at ESMO there were some further presentations on this study. And then also an interesting field where there is more and more interest, if you compare that with 4 or 5 years ago, is the neoadjuvant treatment, and to come out and to look at what is now the best strategy in patients with either borderline resectable or patients with unresectable disease in this setting. And our German colleagues have presented the NEOLAP study in this regard in the neoadjuvant setting with 2 different treatment regimens in the neoadjuvant treatment. Can you update us on the results and on the impact, Teresa?
Yeah, they presented the results of this phase 2 trial, randomized phase 2 trial, with patients initially locally advanced. I am not so sure that some borderlines are included in the trial. They treat the patients with gemcitabine and nab-paclitaxel in order to produce some effect in the stroma, and then after 2 cycles, patients are randomized to be treated with FOLFIRINOX for 2 months, or continued with gemcitabine and nab-paclitaxel 2 more months. And then the patient are considered the resection of those patients. And in fact, the surprising for me is that they presented a high response to this treatment and a high resectability, because around 40% of the patients treated with FOLFIRINOX can be resected, with high number of patients with an R0 resection. It's important. So I think in the locally advanced, even in the locally advanced, of course in the borderline, every day we know that we have to treat more of those patients with neoadjuvant treatment. Even in locally advanced, those patients every day with better neoadjuvant treatments can be resected. Our surgeons are better, they are learning how to manage with these vascular resections, and I think every day this is increasing, and this trial demonstrated it, and it impacts in the prognostic of our patients with locally advanced.
How would you treat today a patient in locally advanced pancreatic cancer? FOLFIRINOX, gem-nab-paclitaxel, or would you say let's start with FOLFIRINOX, if the tumor is not resectable, integrate chemoradiotherapy at that moment? What's your common practice in Vall?
Yeah, first of all, we treat those patients, and we present always these patients in multidisciplinary team. It's so important to be all implicated in these patients. We tend to use more maybe FOLFIRINOX for the questioners that maybe you have higher response rate. We have a really good experience with FOLFIRINOX, but we have no data, so it's an impression. And we try to perform an exploratory laparoscopy in all those patients if we do not have a progression disease in the CT scan, because sometimes the surgeons see that there's no tumor around the vessels, and they can resect that patient. So we try to use this strategy.
Yeah, I think that's an important message, and that's also our experience, that if patients who are pre-treated with FOLFIRINOX, that judging the resectability after 4 cycles or 6 or 8 cycles of FOLFIRINOX is not always easy. Sometimes the tumor has shrunk more than what you see on a scan and becomes resectable in this setting. But one of the challenging topics is also if the tumor is not yet resectable, whether we should integrate at that moment between FOLFIRINOX and eventual surgery, radiotherapy in this setting. And some radiation oncologists are in favor of that. We don't do that as a standard in Leuven, but occasionally we do it in some patients. If we don't see a regression on FOLFIRINOX, we may consider doing that. Do you do that often?
Not so often, but normally I use radiotherapy when the patient is not resectable, when the surgeon say to me that's for sure not resectable. As a control, local control, I use sometimes radiotherapy. I know that the APACT 07 is negative in overall survival, but is positive in local control, and also in the time that the patient, it's longer the time that patient can be without treatment if you give radiotherapy. So I give radiotherapy, but normally after the surgeon say to me, this is not resectable.
Yeah, so it's clear that multidisciplinary discussions are crucial in this disease, especially in local disease. Multimodal treatment options may make more patients resectable. We still have to remind that resection can lead to cure in some patients, although many patients still have a relapse, but it's important for these individual patients. And so this multidisciplinary collaboration is important. And two, what we spoke on in the beginning is that olaparib is the first targeted agent in an enriched population, the germline BRCA mutants, which is 6 to 7% of the patients, where there may be some benefit in this setting. So we are optimistic that by further unraveling and working on the molecular biology, on understanding the stroma interactions, on understanding maybe some metabolic pathways, that in the future we will make further progress in pancreatic cancer. So we are always optimistic in this setting.
Always.
Yeah, thank you very much, Teresa, and thanks also to all of you listening to us for this e-cancer educational activity from Barcelona, ESMO 2019. Thank you.